discussion. Now I would like to invite Dr. Anuradha from Jubilee Mission Medical College for the case presentation on cleft palate surgery in a 6-month-old child. And the examiners would be Dr. Mariam Kushi Thomas, Head of the Department, Jubilee Mission Medical College, Thrissur, and Dr. A. Meenakshi Sundaram, Head of the Department, Government Medical College, Tiruvallur.
So before I throw open this presentation to the presenter, I want to tell two things. One is happy news and another is unhappy news for the postgraduates. So one happy news, the medical teachers of Kerala state have decided not to call me as an external examiner to the state. So that is a happy news. But unhappy news, out of my 13 years as examinership, I have failed only one candidate who has not attended the clinical examination. Thank you.
So my patient is a 10-month-old boy who had come to a hospital for surgical correction of cleft palate. He had history of feeding difficulty. He was unable to suck breast milk. He had persistent intolerance of supine position. It was always more comfortable for him to lie in the prone or the lateral. There was a history of snoring, and he had recurrent respiratory tract infections. However, he did not have any active infection when he came. There's no history of apnea, dysphagia, hoarseness, drooling. The antenatal history was normal. His mother did not have any issues. It was a term normal delivery. Milestones were normal till date. He is immunized. There's no family history of cleft palate or cleft lip. And he's a child born into non-consanguineous marriage. An active boy of weighing 8 kilograms. On examination, there was some amount of micrognathia and retrognathia. There was a cleft palate and relative glossotosis. But there was no trismus, no stridor, no intercostal recessions. Chest was clear on auscultation and air entry was equal. Neck movements were normal. Other systems were also normal. So the patient is a 10-month-old boy weighing 8 kilograms with microretrognathia who had come for surgical correction of cleft palate.
Your slide is having a spelling mistake. It is not retrognathia. It is rerognathia you have written. So you have to be very careful at the time of presentation. That is first point. See, now it is very simple. It is a 10-month-old child. So now, as anesthetizing a child, what are all the problems you are going to encounter?
In this case, there are the problems because it is a pediatric patient. Then, because of the disease, so should I elaborate more on pediatric patient?
There are two possibilities. One is as a cleft palate will be a problem for you.
Yes.
Another is as a baby because it is a problem for
yes.
you. Now you tell me in general, what are all the problems you are going to encounter while anesthetizing a baby?
For the respiratory system of the baby is different from the adult. The head is large, the occiput is more prominent. So in a supine position, the neck is actually a little flexed. So for a laryngoscopy, the optimal position is a neutral position. It's not sniffing. They are obligate nasal breathers. They are
so what is the significance of it? Obligate nasal breather. What is the significance about it?
Sir, so if there is nasal blockade, they don't breathe through the mouth. So we should take care, don't injure. Right. Then the angle of the mandible is a little obtuse. They have some amount of tongue fall. Even otherwise, because the tone is less, they are more prone for airway obstruction. So we always have to give CPAP and use oropharyngeal airways because then larynx is a little more higher. Their vocal cords are angled. Epiglottis is large and floppy. So it may be useful to use a straight blade, laryngoscope blade. Then if you pass an endotracheal tube blindly, it would more possibly go and hit at the
Why you
commissures.
are passing it blindly?
Sir,
Why
that
you are passing it blindly? You are
No.
saying when you pass, why you are passing it blindly?
okay. No, sir.
So which is the narrowest portion of?
The narrowest portion is the it's the cricoid. It's a subglottic region. So you can use uncuffed tubes.
No, what is the significance of it? Subglottic region. Because in the adult glottic region is the
Yes.
narrowest part. What is the significance about it?
Significance is there should be some amount of air leak around the tube after you intubate. They are more prone for
You are not clear about it. See, in the adult, glottic portion is the narrowest portion.
yes.
So if suppose you are selecting a 7.5 tube, if you guess 7.5 is the ideal tube,
Would be
you will be
ideal.
pushing the 7.5. So in the child, if you guess it is 3.5, what can happen at the time of intubation?
It may be more tight. You may actually need to use a 3 because
Because
when we
a
look,
tube which is passing through the glottis may not pass through the subglottic
may
area.
not pass the
Right.
subglottis, and we should not push through. Then the lungs are smaller. The
Lungs
close-
will be smaller only.
yes, sir. The closing volume is within the tidal volume, so they are more prone for atelectasis. Then they are then
No, actually you have to talk in terms of physiology. If you are coming
Yes,
for
sir.
lungs, what is going to be the physiology? What is the oxygen demand actually?
oxygen demand is much higher.
Then you have to talk about compliance.
Yes, sir. The lung compliance is less and compliance of chest wall is more. Then in the diaphragm, the muscles of the diaphragm are not very fatigue resistant.
What is compliance?
Compliance is how much it moves.
What is compliance? How much it moves? It is
How much it moves with the
volume change to the applied pressure.
volume to pressure.
Volume change to the applied pressure.
Volume, yes. And the diaphragm is less fatigue resistant. So they
Means-
tend to they'll fatigue more easily.
Cardiac system?
Cardiac system, the amount of myocardial contractile tissue is less. They have, their cardiac output is rate dependent. Their response to sympathetic stimulation is less. So it's important that the heart rate is always maintained and child doesn't go into bradycardia.
So what is the respiratory muscle oxygen demand for the adult and for the child?
So the oxygen
Demand.
is double in child. That is maintained by the respiratory rate, which is almost double as the adult.
Again, minute volume is also rate dependent.
Yes.
Minute volume is also rate dependent.
Rate
right?
dependent.
So what is the difference in thermoregulation?
They are more prone for hypothermia because the thermoregulatory system is not well developed. Also, the body surface area
See,
compared to the
it is
weight.
not well developed means what? Every development will come only in stages. So
Yes,
what's the
sir,
big difference? Then you can very easily say in pediatric everything is underdeveloped. You can say kidney it is underdeveloped, development, liver it is underdeveloped.
I know it's not.
What is
Sir,
the thermal regulation? You tell me. What is
So
the problem?
the head alone occupies about 20% of the body surface area, and the ratio of surface area to weight is more in a child. So that is so they are more prone for heat loss.
That is right. That is because of conduction, large head it is happening. But how the thermogenesis is maintained? See, that is the main
Yes.
idea. Why thermogenesis? Because there is a point. There's a point in
Yes.
asking that question. How thermogenesis is maintained?
Sir, it is by
How we maintain if the AC room, if it is so chill, what will happen to us?
yes. The brown fat is in neonates.
Correct.
That's up
You
to
are
3
worried.
months.
How brown fat is used in thermogenesis?
So brown fat actually generates heat
Where
when
it
there is
located?
sympathetic stimulation.
Where it is located?
It is between the scapula,
Only one area.
interscapular region, and near the hips. interscapular
Over the
region, sir.
adrenals, in the interscapular region and over the adrenals. But what is brown fat exactly?
It contains cells with more mitochondria, so it converts ATP to heat.
It's a lipopolysaccharide, but the point is it requires two things for it to be to get stimulated. One is the sympathetic nervous system, good intact sympathetic stimulation. Another is oxygen.
Yes.
Another is oxygen. So now you got a point why I am asking this question.
Yes, sir.
If the patient develops hypothermia, baby, it can develop hypoxia because oxygen is utilized to power energy. So if the patient develops hypoxia, the baby can develop into hypothermia. So both the things will go together.
Okay.
And another problem, if the case is, now it is a corollary, if the baby is suffering from phallostetralogy and it is on some drugs, whether it has any problem with the thermogenesis? Because now I asked three questions in this. You should know what is phallostetralogy, what are all the possible drugs in that, and how it affects thermostasis in the newborn, thermal regulation.
The drugs given are those which reduce SVR in fallows.
What are all the drugs that can be given to reduce cyanotic
Nitrates.
spells? To reduce cyanotic spells?
Nitrates are given, sir.
Nitrates.
Isosar.
How will you treat cyanotic spells?
Cyanotic,
Spell. What is tetralogy of Fallot? Components of tetralogy of Fallot?
there is RVH, there's an overriding of aorta, then pulmonary stenosis, and VST.
VST. And what are the drugs they will give? See, you are saying pulmonary. You are saying pulmonary stenosis. It is a right ventricular outflow tract obstruction. We say like
Yes.
that. So we use some drug. We can use morphine. One. What is the second drug we will use? We will give oxygen. We will give morphine. Then the positioning.
Positioning is
That and all over. I want that particular drug which has some relevance with this thermal. See, I told you, no, it requires oxygen and sympathetic innervation.
yes.
So if any,
I am given alpha agonist.
no, I'm
phenylephrine.
asking about cyanotic. See, right, the propranolol will be used. Propranolol is the drug used to reduce cyanotic spells. Now my question is, if a child is receiving propranolol, will it have any effect on the thermal regulation of the newborn?
Yes.
What is the thing can happen?
Because of reduced sympathetic stimulation, they are more prone for hypothermia.
So that's the question. So how will you assess this child?
Sir, from the history, what I would like to...
What is the problem with the cleft palate? As a child, we have so many problems.
Yes.
With the cleft
Yes.
palate?
With cleft palate, from the history, I would specifically ask about...
No, what are the problems? Because it is a short case, we have to finish it now.
Okay, sir. Sir, you're asking
What are all the
problems?
problems you encounter with the cleft palate? No, if there is a normal palate, sometimes it will be convenient for you. With the cleft palate, what are all the problems? As an anesthesiologist, what are all the problems? you
airway,
anticipate?
securing the airway may be more difficult.
What is the difficulty?
Mask ventilation may be more difficult.
Yeah, you have to explain. See, it is very easy to answer. It will be difficult, it will be difficult. But anticipation is what sort of difficulty you are thinking it will happen.
Because the mandible may be smaller, making
Maybe
mask.
smaller.
So
This
this
mandible-
small in this
No,
child,
I'm asking what difficulty you will encounter because of that.
I may not be able to mask
That's what you have to say. You
I may not be
because
able
of
to
right.
mask ventilate. I may not, laryngoscopy may be difficult.
Why laryngoscopy is difficult?
Because of the cleft, the blade may slip.
May get stuck in that cleft.
Then it's a shared airway with the surgeon, and there's a very high chance of accidental
You are not supposed to say
extubation.
it is a shared airway. There is a competition between the surgeon and the anesthetist. It is not a airway, right?
Then there's a very high chance for accidental extubation as well as endobronchial intubation. Should be checked at several points. Then post-operative, then there may be bleeding during surgery, then hypothermia.
How you have identified there will be bleeding during surgery?
You have
Any surgery it will bleed.
you should watch the surgical field and tell the
So how
surgeon
will
to
you
tell
assess?
you.
How will you assess now? How you are going to prepare the patient?
Prepare.
You want to ask for any investigations? Or
Yes,
straight away will
I
be
want hemoglobin because these children may have some amount of malnourishment or anemia. Then I would like WBC count to see if there is any infections, blood group and RH, and cross-match 1 unit of packed red cells and viral markers.
viral markers. Why?
Yes, sir. That's routinely done.
Routinely done in your
Yes.
institution.
Yes.
Good. What are all the viral markers you are doing?
HIV, HBsAg, and HCV. Routinely done,
Fine.
sir.
That are the viral markers, is it? Then you can say HIV, HBsAg, you will test. HCV also you are doing.
Yes.
Good. Universal precaution. How many gloves you are wearing at the time of intubation? How many gloves you are wearing? One. I am happy at least you are wearing one. Then, how will you premedicate this child?
Sir, I'll give oral atropine at 0.16 milligram. I'm not giving him midazolam because...
Why oral atropine?
Sir, because I would prefer to do inhalational induction for him and put an IV line after inducing.
So, theoretically, see, we say if the child cries, it will create problem. If it is like hydrocephalus they have presented, there is a chance of increased intracranial pressure. As a beginner, because you are not yet qualified, I ask straight question. Are you so sure it will be always safe to induce the child then secure IV line?
No, that wouldn't be the safest.
So, I personally feel a beginner, this is apart from the examination. See, never venture without a IV line. Unless if something happens, how will you manage? That is a problem. So, always be on the safer side. In exam, whatever you tell, this one question and answer will not determine your percentage of pass. So, but anyway, to be on the safer side, better you secure a IV line so that the managing the complications will be easy. Right? You are giving oral atropine. Then?
Okay. So, then before taking up the patient, I would check the machine, the monitors and airway equipment, difficult airway card.
That and all over, because the time will be running.
Okay.
You will be managing everything. Oral atropine.
Okay.
Then what you are going to do?
Then inhalational induction with SIVO, with sevoflurane.
No,
and
you have to
oxygen.
tell everything. You are not so. I don't know what is inhalation induction with the CO. Okay. What you are going to do, I am asking. You are given oral atropine.
Yes. Then using oxygen and sevoflurane, I will induce the patient and I'll check if I'm able to do bag mask ventilation. IV line is secured. And if I can ventilate easily, I would give muscle relaxant, heterocurium. I'll give an opioid. And then...
See, now totally I don't know what you are doing with the child. Very clear, because you have said you will give oral atropine, oral atropine. So now what you are going to do, you say with the oxygen and the CO and a bag mask, when I will induce the child, I will check bag mask ventilation, I will secure IV line. Totally, I could not guess what you are doing. You have to say what is the flow of oxygen, what is the flow of nitrous oxide, what is the percentage of sevoflurane you are going to keep, when you are going to secure the IV line, when you are going to check for, because it is routinely you are doing.
Yes, sir.
See, this examination is just a rehearsal for you to say what you are doing.
Okay. Oxygen will be kept at 10 liters.
Oxygen? 10 liters.
Yes, sir.
That is the highest level in your rotameter. Oxygen 10 liters. I don't know, the highest level will be only 8 liters.
8 liters in a boils.
So, your bobbin will go to ceiling then.
Though it's a...
Tell me, 10 liters.
No, if it's a boils, keep it
No, how much of oxygen flow you will keep?
So I'll keep 6 liters.
6 liters.
Yes.
Idea? What is the idea of 6 liters?
Sir, actually you can use a
No,
mixture
no, I
of,
cannot use. See, you use, if
a
at all you want to
mixture
use,
of
you use.
oxygen and nitrous oxide can be used, but for this patient I would prefer not to use nitrous oxide.
No, I am asking why you are going for 6 liters. What is the magic number 6 liters? For this 8 kg child.
The fresh gas flow should always be thrice the minute.
Then work
Ventilation.
it out. Work it out. What is the tidal volume? See, unnecessarily you are becoming a mathematician, Ramanujam. See, 8 kg. Now you work out the tidal volume.
Yeah,
What is the
it will
tidal
be
volume for 8
it will be
kg?
80.
Huh?
It will be 80.
80, huh?
Yes, sir.
So 10 kg. It's the tidal volume of the patient, is it? 10 ml per kg.
8 to 10 ml per kg.
Oh.
And that into 22.
In our region, it will be only 7 ml per kg for my child. I don't know. Anyway, it is your child. 10 ml per kg. 80. Work it out. What is the
So
respiratory
rate would be
No,
22.
now you work it out.
22.
rate? 80. Rate?
22.
22. Work it out. So 1600, 140. 1740.
Yes, sir.
Now you multiply it 3
1760.
times. Even then it will work out to only 5100. And 1 2.
5.1 liters.
Then you are going for 6 liters again.
So that, okay.
6.
Fine. 5.
Now you are accepting. I am happy. Right?
5 liters. That
5
would be
liters
3
will be-
times the minute ventilation.
Pardon?
5.1.
What is the percentage of sevoflurane you will keep?
I'll keep it at 8%,
8%.
the highest.
What is the percentage available in that dial?
8% is a maximum. But as soon as a child becomes unconscious,
So what is the circuit you are going to use?
Jackson-Rees modification of ISTPs. As soon as the child becomes unconscious, I'll reduce the
How
dial.
will you check the child become unconscious?
Sir, there's no response to a jaw thrust.
No response to a jaw thrust. So what will be the normal jaw thrust response?
It's quite it's really painful. Then,
For the baby. How will you locate?
then he wouldn't move when you put an IV cannula. That also means the child is sufficiently under.
Then you will do a trial laryngoscopy, is it?
Sir, after putting the IV cannula, muscle relaxant would be given. That is, first I'll confirm that I can easily do mask ventilation. If I'm not able, in this child, I'm able to mask ventilate. So I'm giving atracurium and waiting for...
No, why you are interested in using atracurium? Why not a depolarizing muscle relaxant?
If I'm not sure about mask ventilation, if I think that intubation would be difficult, then I would give a shorter acting one.
If you are anticipating difficult intubation, you are not supposed to use a relaxant. See, that is a basic dictum. Now you will take it from me. If you anticipate any difficulty in intubation, it may be there or may not be there. If you anticipate, don't venture with the relaxants. That is the reason you are using all these sevoflurane, 5 liters of oxygen, everything. Never venture with relaxants.
Yes.
But why you are hesitating to use succinylcholine?
Because it's a boy and
It's a boy.
and there's
But
a
the girl you
rare
will use, is it?
and
Gender
a small
discrimination
risk
is
of
acceptable.
myopathies, small risk of neuromuscular disorders.
That's your imagination. Anyway, it is your choice, your child. Atracurium.
Sir, if I the other option is to increase the depth of anesthesia with on sevoflurane inhalation, so that the spontaneous breathing is maintained, and then do intubation.
When you will keep nitrous oxide?
I would on the nitrous oxide after securing the airway.
Which tube you will use?
Pardon, sir?
Which tube you will use?
A south facing preformed RAE tube.
South facing.
South pole
South
RAE
pole.
tube.
Because I don't know where is south.
South pole RAE
facing.
tube.
So what is RAE?
Ring Adair Elvin.
What is the advantage of using that tube?
One is the shape of the tube. It lies in flush with the oral cavity, so it lies within the gag which would be applied. So it's convenient for the surgeon also.
Can you use preformed tubes?
This is a preformed tube, sir.
What are the other preformed tubes you know of?
Oxford tube. It was used previously. Now it has gone less out of favor. Then those are the two tubes.
So how will you, what are the monitors you will apply?
Precordial stethoscope, pulse oximeter, ECG monitoring, non-invasive BP, temperature probe, capnograph.
Now I'll ask one question. Instead of struggling with all these things, if a child, if it is brought into the room with the mother's lap, can you give intramuscular ketamine so that the baby will be under?
Yes.
Then you can secure your IV line, you can use your relaxant, you can intubate.
Yes, sir.
Yes, accepted?
Yes.
Accepted? So
Yes.
in ketamine, what are all the reflexes that are maintained?
Ketamine airway reflexes are maintained.
So what they are going to do now?
We are going to intubate. So,
Sir?
no. If you give ketamine,
No.
you can give ketamine as a pre-medication and bring the child onto the table. But on table, you secure an IV line and give a relaxant and then intubate.
So post-operatively, can you place, if suppose the surgery is over within 45 minutes, can you place, if the tongue is falling back, what is the maneuver you are going to do?
So, a tongue stitch would be placed in palate surgeries. Then give a jaw thrust and a chin lift.
See, once his tongue stitch is made, then this jaw thrust is
No,
necessary.
it's usually that stitch is pulled forward to avoid
What
tongue
is the
fall.
analgesic you are going to give for the post-operative period?
At the start of surgery, I would place a paracetamol suppository.
But now surgery is over.
Yes, after induction, I would place it, sir.
So that is the post-op analgesia you are going to have.
Yes.
Right now it is for madam, for 4 minutes only more. I am dragging that only.
I think there's been a very lively discussion packed with humor. Just to interrupt and ask you, you said something, I think you probably needed to clarify. If you could hold a mask and ventilate, even if you called it a difficult intubation, it is okay for you to give relaxant. You don't have to give inhalational induction and intubation. Okay. Second is, you said, what are the problems that can happen during a surgery for a cleft palate? What are the intraoperative problems? Can you list them out?
Madam, one is because of the positioning, the chances of extubation or
Okay.
endobronchial intubation. And
Why
The-
would endobronchial intubation occur?
because they keep changing when they change the
How is the
position,
neck positioned in the surgery?
neck is extended.
So, would the tube go in or out? More commonly,
There is
more
a higher
likely
chance
that
for
it comes out,
extubation.
isn't it?
But because the surgeon is manipulating very close to it.
Okay, I haven't seen that endobronchial, but maybe you have. Anything else?
Rather than hypothermia,
Yeah, that's where. Is hypothermia so common in airway surgery? Despite it being pediatric, and actually there are reports that the child gets hyperthermic and you don't need to do active rewarming in pediatric children undergoing cleft palate surgery. So strangely, I don't know what the reason they have given. There are several reports, papers actually, which say that the child gets hyperthermic during cleft palate surgery. Yeah, it does happen, and there are papers on it.
Once you induce and you give the relaxant and you do a laryngoscopy, you don't get an optimal view. What are your options?
I would use external laryngeal manipulation or a bougie and see if I would be able to improve the view.
Anything else? Any other approaches? Any other blades?
I'd then change the laryngoscopy blade. Then the next option would be to go for fiber optic bronchoscopy if not really.
You have to wake the child up before doing fiber optics, isn't it? Oh, one. Do you have approach a paraglossal approach or with the straight plate? Especially helpful maybe in this case, these sort of cases.
So you can keep a wet gauze over the palate
You should keep a,
Wet
first thing is
gauze.
to put a gauze in the cleft
in the
and
cleft.
try various approaches.
Yes.
What is your modality for pain management in this child?
At the start of surgery, I have given opioid, fentanyl,
Okay, how much?
16 microgram.
2
Say
mics per kg.
2 mics per
Okay,
kg.
right.
And I'm keeping paracetamol suppository of 30 mg per kg. And for post-op, I would...
What is the dose of the suppository available for pediatrics?
160, 250, 170, 250.
Okay, so you would join two, the 170 and 80 to give your dose, right? 30 mg per kg would be 240, right? Okay, so you give that at the start of surgery, then?
Then in the post-operative...
Intraoperatively, how do you manage tachycardia and hypertension that occurs? What is your algorithm for management? Nothing? Surgery could take as much as 2.5 hours? Don't know if your surgeons are fast, ma'am, but...
2 hours. Just around 1.5 hours.
Okay, right. So would you
Madam,
supplement?
intraoperatively, I would look at the vitals.
I'm telling you there's hypertension in this hypertension meaning a rise in the blood pressure by 20% from baseline.
Yes.
Then?
So then I would increase sevoflurane and supplement opioid.
How much?
That would be
Quick.
0.5
0.5 mics per kg
Could
to a
be,
maximum
yeah,
of
1/4
about
the
1 to
starting.
2 mics per kg per hour. What is a post-operative pain assessment? Like you have a numerical rating scale for an adult. How do you assess pain post-operatively? What is that scoring called?
Under the faces.
Okay. The other one? No, faces also you have to record, isn't it? Flax scale. Have you heard of the flax scale? Yeah? The face, legs, activity, color and cry. That is, every postgraduate should know. Probably we all don't emphasize that much. You should know what is a modality of pain assessment post-operatively. This is a universally accepted thing. There is that Wong's faces which can make an assessment, but this flax scale is a little more objective.
One last question. You extubate the child and the child develops stridor. How do you prevent that stridor and how will you manage it?
Always under gentle laryngoscopy should be done, and suctioning under direct vision should be done.
How will you prevent it first? How will you prevent stridor?
So suctioning is important so that there's no residual clot or secretions. Ensure that there is no retained surgical packs. Then look for edema of the tongue, the palate. Even the pharynx may have edema because of laryngoscopy. Then extubate only after the child is fully awake. Reversal of neuromuscular blocker should always be given. And after the child is fully awake, it's extubated.
Is there any manner while extubating? You do something while extubating? Or you just pull out the tube when the child is awake? You do something?
Yes, I'll give a jaw thrust.
No, you put the lung into something, total,
I'll give a positive
give a positive pressure.
pressure ventilation and remove it.
That could prevent. Then suppose, okay.
And immediately turn the child into lateral position.
Suppose the child has developed stridor, then what will you do?
First, I'll give a positive pressure ventilation. So is it laryngospasm?
Yeah,
Yes.
please.
Okay.
Is having a crowing sound and saturation is coming down slowly. It's now 90.
I'll give Larson's manure, give positive pressure ventilation, and give some amount of intravenous propofol. And still, if it doesn't break, then succinylcholine.
Would you give something before giving succinylcholine? Or you give
Yes,
succinylcholine?
atropine.
Yeah, only don't, yeah, fine.
Atropine.
You give atropine first and then succinylcholine.
Yes, sir.
Dr. Anuradha, you have done very well. I know the reason behind it. Because I already informed her that I will not come as an examiner. So she was comfortable. You have done very well. Because only in 2 areas, if a junior is more popular than us, we will be happy only in 2 circumstances. One, if it is going to be our son or daughter. Number 2, if it is going to be our student. Now you have made me awake. Thank you.
Thank you, sir.